Hello Insta fam, it's Dr. T here, coming to you on a Wednesday night a little later than I usually would and somewhat unannounced. It has been a few weeks, I must say. I've had a little hiatus from social media and I've got to tell you, I've actually just enjoyed a little bit of time out. So I'm just going to wait until a few people jump on. I've got to share something with you guys. Oh, lovely to see you guys back on here as well. I had a little mishap last week while we're waiting for everybody to jump on. I had some chest pain, like chest wall pain, just around the side. And I thought I'd pulled a muscle, and I was asking all my physio friends and all my doctor friends, and it was just a little bit hard to breathe, hurt a little bit to breathe, and then it hurt to kind of lay down at night time, and we were all thinking, oh, was it a pulled muscle? Am I going to develop some shingles? I've been working pretty hard, pretty stressed, not sleeping very much. And then sort of Friday afternoon, I was actually quite tired and quite breathless, and the anaesthetist I was working with said, don't you think you should go to the hospital and get checked out? And I went, yeah, probably should go and do that. A couple of hours later, Tamara Hunter, you have a pulmonary embolism. Yep, PE in my lung. I left lower lobe. Couldn't believe it. I had actually done a flight to Melbourne the weekend before to go to the SEED conference. So I learned a lot, but I got a lot of pain for my journey. So, that was my little sojourn last Friday night. And it was one of those moments where I know, right? I had one of those moments, it was kind of a bit of a feel sorry for me moment, and I know you guys know this, where you fall over yet again. You fall over yet again, and you know you've just got to pick yourself up, you've just got to brush yourself off, and you just have to keep moving. But it's just one more thing. And I really thought to myself, gosh, I did look up to the heavens and sort of say, what am I supposed to learn from this? But it was. I spent the weekend feeling just a little bit sorry for myself, as many of us do when we have these sort of constant fail forward moments. Just sort of thinking, what's the blessing in all of this, Tamara? Yes, I got a weekend of rest and I got to hang out with my family, and, maybe that's just another reminder that I need to slow down a little bit. But I did think of a lot of you guys who have these kind of fail forward moments where, you just, gosh, it's another non-pregnancy, or it's another miscarriage, or, it's another IVF cycle with no embryo to transfer. And it's just kind of disappointment after disappointment after setback after disappointment. And I totally resonate where many of you sit, and just those moments of, being exhausted with it all a little bit. So completely understand if any of you have been in that moment where you just kind of want to curl up in a little ball and not really speak to anyone or do anything. I definitely had one of those moments over the weekend. But as you do, you kind of pick yourself up, brush yourself off, and you keep moving forward, don't you? Because you just have to. There's no other way to go. Anyways, enough. Even my cats had a gutful. Yeah, totally. I know. I did sort of say that. I've had a gutful, absolutely. So anyway, guys, I am here for you. Bit of a Q&A session. I have actually had a couple of really aha moments over the last couple of weeks, a couple of interactions with some patients, and I've kind of been journaling. So I'm going to come back to you with a few little sort of videos of some insights that I think I learned over the last few weeks and interactions with patients. But tonight is about Q&A. So if you have any weird little questions, please don't hesitate to drop them in the comments. Like I said, everyone, make them as generic as possible. Please don't give me your whole life story. I will try to make the answers as generic as I possibly can, and as short and sweet, though, as you guys know, time with me is often very, very rarely short and sweet. Somebody also asked me why I do this, why I give this time away freely. And it did sort of have me stopping and thinking about, where I started with this journey. Oh, Life of Brit, I'll come to your question in a sec. where I started with this journey and the reason that I came into this social media space was I wanted to fill the space between where people were getting a lot of misinformation and the fact that a lot of sort of traditional Western evidence-based medical practitioners didn't want to venture into the social media space. They just felt it very sort of embarrassing. Maybe some of them even felt it was a little bit below them. And so I just want to remind everybody that my purpose for being here is to kind of fill that void of information, to make sure that the information that I'm sharing with you is evidence-based, that it is balanced, that, I'm giving you the important information for you to then take away and consider, so that you don't have to go down the Google minefield of information that may or may not be out there and may or may not be true. So let's come back to the question, shall we? Life of Brit. Can you get prescribed progesterone support a few months before an IVF cycle, or do you only get progesterone support once you've started a cycle? Okay, so progesterone, micronized. There's progesterone and then there's progestogen. So progestogens are a group of synthetic medications that are made to kind of be like the progesterone that your body produces. These progestogens are not really thought to be that valuable in supporting early stages of pregnancy, so we tend not to give them. Micronized progesterone is kind of the equivalent to what your body, so I suppose for want of a better term, it's bio-identical to what your body would produce. And there's lots of different preparations that it comes in. It comes in compounded forms. It comes in pre-prepared commercial pessaries. You can get micronized progesterone orally. It doesn't seem to work as well as vaginal pessaries. And you can even get it in both intramuscular and subcutaneous injections, which the intramuscular are thought to be the best support, but as we know, there are complications with intramuscular injections. So you can get this stuff commercially. Like your GP can prescribe this stuff for you. The question is, at what point do you know to introduce it within your cycle? Because if you think about it, you have an LH surge, then some 12 to 24 hours after you have an LH surge, you will ovulate. And at that point, you're going to convert from producing predominantly or producing estrogen to then switching to producing predominantly progesterone and some estrogen. And we don't necessarily know exactly when that time point is. So as an average, we will trigger you. So that's like your LH surge. Then you will ovulate some 12 to 24 hours after that. And we will generally introduce the progesterone a further 24 hours after that to simulate when you would be producing progesterone. But how do you know that when you're doing ovulation testing kits? You probably won't. How will you know that if you're doing serum testing? Well, only if you're doing serum testing right up to the point where you see your surge, will you know then when to bring progesterone in. So the progesterone is really only important, but is the most important hormone in that second part of the cycle, covering over that window of implantation. So hopefully that answers what you were trying to get out of that question, Life of Brit. Michelle Arnold, lovely to hear from you. Thank you for sharing and being so real about it, how it made you feel. Yeah, it made me feel crap. Hope we appreciate the authenticity and fingers crossed you feel supported. Someone in that space too. Yeah, you know what, I kind of did, but here's another little aha moment for me. And I know many of you guys would feel it, and I know, Michelle, you are a patient advocate. And that is that in the private healthcare space, you are your strongest advocate, 100%. Like there isn't an area of medicine, whether you go from cardiology to oncology to fertility medicine, you are always going to be a far bigger advocate for yourself than your doctor, than your nurse, than the secretary, than your GP. I promise you, you will have to advocate for yourself way more than you perhaps need to do in the public health care space, where you kind of just get guided along a little river. It's kind of like when you're at Disneyland and you're sitting on those little boats that are taking you down the river, or at Adventure World, wherever you've been. And you kind of just have to stay on those boats and kind of get dragged down the river, and you get exposed to things as you get exposed to them. Whereas in the private healthcare space, you have to advocate for everything. You have to advocate for, have you referred me for imaging? And, when are you going to send out that blood test form? And I know that patients certainly have been the squeaky wheel for me in getting things. And I think that is really important, that it's okay to be the squeaky wheel. Be respectful about it, 100%, be respectful about it. But I think being the squeaky wheel and learning that you are going to be your advocate and nobody else is actually a really important message in the private healthcare space. Mum in the making, how long should you be on progesterone in pregnancy? Great question. I think it is very dependent on your obstetrics and pregnancy history. Most people, when we are giving it for luteal phase support, can be weaned off it by around about week 10, and most people are off it completely by about week 13. Those in the context of recurrent pregnancy loss, particularly in the context of bleeding, are probably encouraged to be on it right throughout pregnancy, and those who have threatened preterm labour certainly are encouraged to be on it throughout pregnancy. So I don't think I can generalise that statement, but hopefully you're in one of those categories. Shalene, 91, welcome. Multiple implantation failures and miscarriages. Next step. Oh my goodness, my friend. That's a big question. Absolutely get yourself referred off to a fertility specialist. Absolutely. So just again, by definition, recurrent implantation failure is when you have had 3 or more good quality embryos transferred in an IVF setting. So that's recurrent implantation failure. Recurrent miscarriage obviously is spontaneously conceived or otherwise pregnancies that have implanted and continued for a wee while. It can be biochemical, i.e. you never saw a fetal heart. It can be a clinical pregnancy where you saw a fetal heart, or even beyond that. And then you have miscarried. So absolutely you should see a fertility specialist, preferably one who is well versed in RIF or RMC. And then you need a full workout. Now I could spend an hour talking about all the different things that should be tested, but let me just give you a synopsis. The most common cause of miscarriage, sorry, that's my dog under my feet. The most common cause of miscarriage is chromosomal abnormality. So get your chromosomes checked and understand that 50% of miscarriage loss is due to abnormalities in the baby. Endocrine screening, thrombophilia screening, anatomical screening of the uterus, looking for polyps, fibroids, septums. Consider whether or not you get a screen for endometriosis, chronic endometritis. Male factor, looking at sperm DNA fragmentation. Then you start to go down the proverbial rabbit hole and look at things like immunological tests. You try natural killer cells, microbiomes, yada, yada, yada. So very difficult area of medicine, but absolutely you should have someone go over you with a fine-tooth comb. Hope that helped. Amy Mammy, would you consider doing a podcast? Me do one? Or just me participate in them? Do you know what? I have been asked hang on a sec. What are you doing? It's my dog doing something under the table. Oh gosh, I should tell you the stories of Winston. So many of them. I have thought about doing a podcast before, and what makes me slightly scared is the number of hours of preparation that it would take me. The soundproof room, of which I do not have one in my house, and having to come up with the topics. So look, why don't you guys put me forward to be guests on someone else's podcast? I am very happy to do those, and they're lots and lots of fun. Stevie Adamini, I'm so sorry, Steve. What are your thoughts on embryos that are genetically tested and come back with a no result? Oh, okay. Slightly challenging question. No result can mean a number of things. So when we genetically test, we grow them out to day 5, we make a small hole in the zona pellucida, we take 5 to 10 cell biopsy out of the trophectoderm cells, the outside cells, not the inner cell mass. That embryo is frozen, and then those cells are sent to your genetics lab. In the genetics lab, they chop up all of the DNA and then they amplify it. So polymerase chain reaction, they kind of grow, because you can imagine 5 to 10 cells are tiny, so it's too hard to analyze those. So they have to multiply all that DNA, so they grow it up. And then they chop the DNA up into lots of little pieces, and then they analyze it on different platforms. Everyone uses different platforms. Not all PGT is the same. So you can see already there are multiple places where things could go wrong. Number one, biopsy. Perhaps they didn't get enough cells at biopsy, so therefore they couldn't grow up the cells, therefore they couldn't amplify the DNA. Number two, failed polymerase chain reaction, so failed DNA amplification. That can happen, the cells just don't grow. Number three is the DNA itself was poor quality when they came to analyse it, so they couldn't analyse it. And number four, the analytical methodology just was not sound. So a no result can mean any of those things. It doesn't necessarily mean you've got a poor quality embryo just because you get a no result. That's different to, say, an inconclusive. Well, it depends. Depends how your lab that you use has classified things. But that's often different to an equivocal finding. So it would always be worth a discussion with the scientific director in charge of genetics as to whether or not you would consider rebiopsying. Now, again, it depends on the quality of your lab, both your embryology lab and also your genetics lab, as to what harm they think it might do by rebiopsying the embryos. But I definitely think that is a discussion point. Now my dog is trying to open the door. Fabulous. All right, moving on here. Caitlin R. Hi, any tips for self-care during an IVF cycle? I know it's personal, but would love any great tips you have had, do's, do nots. Okay. Do not plan to travel during an IVF cycle. Do not take on any big health kicks during this time. This is not a time to do a CrossFit challenge or radically change your diet and go vegan. Just eat moderately, eat abundant colours, don't drink, don't smoke. I mean, you guys know those ones. Get good sleep. I think that's really important to deal with the stress and burden of IVF. What else is really important? Do have sex. I think that's really important. It's an important part of this bonding process. And apart from after you trigger, where we say please don't have sex, it's okay to have sex. It's important to have sex. It's even important to have sex after your embryo transfer. Do not lie down after your embryo transfer. The evidence actually now says it increases pregnancy loss by lying down after your embryo transfer. It will not fall out. Even when you go and empty your bladder, it will not fall out. So, yeah. And anyone want to do the experiment on Macca's chips after a embryo transfer? I'm super keen to do that study because I'd really like to know if they are truly better than KFC chips. All right. Anyone else? Anyone else? Is that Teus? Hello, my friend. Anyone else? Danny Paxton, what is your recommendation for days following transfer? Can you exercise as normal? Should you watch that heart rate stays under a certain level? Well, that kind of continues on from our embryo transfer question. Yes, go back to exercising normally. Now, if your normal exercise is going and doing CrossFit every single day and then hanging out in the sauna or doing Bikram Pilates in a hot room, probably not. I mean, I think it's about being sensible. But look, if you're a runner and you get great relaxation from going for a run, then go for a run. If you're a swimmer, go for a swim. There is actually no evidence as to whether you should or should not be doing exercise after an embryo transfer. And at this point, if it's something that you normally do, then be normal. Alrighty, I'm going to take one more question if there are any more. Thank you guys. As I said, I haven't been on here for a couple of weeks. It is lovely to be back on and back in the swing of things. I have a couple of weeks where I'm around, and then I'm heading off to ESHRE. This will be my first trip to the European Society of Human Reproduction and Embryology meeting, which is being held in Amsterdam this year. It is my first ever in 14 years. I've always been that fertility specialist that was left behind to do all the egg collections while everybody else went to ESHRE, but I am getting to go to ESHRE this year and I am super duper excited about it. I'll have lots and lots of new information to bring back. Were there any last questions? Is anyone furiously typing away their final question before I wrap things up? And yeah, just a reminder to everybody why I do this, why I give my time away freely, but is it really free? I mean, we can all be doing something else right now, right? Why I do this, because I think it's important to empower you with the correct knowledge. It's important for me to fill that void that I think exists from fertility specialists who are trained, who do dozens of years in this area. It is important for us to fill that void of misinformation and mythology that is out there. It is important for us to direct you to the correct sources for information, because we want to make sure that we meet your expectations on your patient journey and that you are empowered and educated in the right way. So one final check. Nope, no more stories for tonight. Thank you so much for joining me. I will see you next Wednesday night. I don't know what time it's going to be. I'll try and make it earlier, but look, lots of you guys were on. Oh, Staffy Mama, you got in one last time. One last question. Fresh versus frozen success rates. Here lots. There's not a lot of difference, but Monash latest published rates show significant difference. How does one interpret this data? I suspect what you might, the latest data around frozen perhaps being slightly more impressive than fresh. And it might be that it's associated with that physiological state. But you gotta think there's a lot of complicating factors in there. A population of people who are doing frozen rates is probably a slightly better population than those who are doing fresh, because sometimes people who get a fresh transfer might not actually get a frozen. They might not get enough embryos to freeze. People who do freeze-alls, for example, might be doing genetic testing, or they might be people who are at risk of ovarian hyperstimulation syndrome, so they might be a younger population with a much higher number of eggs. So I don't necessarily think that we can compare apples and pears. I would always be very cautious in considering that data. We have always felt that it's probably comparable, that fresh rates probably do equal frozen rates. But yeah, watch this space, because I can honestly tell you every year it changes. And it's important to understand that the drugs change as well. The drug preparations change as well. The one thing that I do think we are moving more and more towards, though, is natural cycle FETs over synthetic cycles like HRT FETs. The data does seem to be suggesting better pregnancy rates with low-dose stim, and also better pregnancy outcomes with less preeclampsia. I'm going to go and rescue my children from my enormous dog, and I will see you guys next week. Bye.